Hello, my name is Laurie Zoloth. I teach at the University of Chicago. And for one glorious summer in 2018, my colleagues and I spent time thinking together about bioethics and with a variety of lenses. But one thing we all agreed on was the central importance of justice to every question in bioethics. So it's our great privilege and honor today to take you through the various lenses that, with which people looked at the COVID epidemic, the pandemic that swept across all of us, all of our countries, all of our research. As we turned our attention to this, all of my colleagues here in our diverse and wonderful group decided that what we want to mostly focus on is the extraordinary injustice that was revealed clearly by the pandemic. So I'm going to give my colleagues a chance to talk. And at the end, I will make a summary comments. We have so many good speakers here today that I want to begin. I'm going to start with Dr. Previn Moody. Dr. Moody is a senior lecturer at the Department of Psychology at the University of Johannesburg in South Africa. Previn.
Hello, everybody. Hi. Professor Zoloth, do I have 10 minutes? Or how much time do I have?
1, 2, 3, 4, 5. We now have 1, 2, 3, 4, 5, 6, 7 people and an hour. So let's each do 5 minutes, and if we have time for discussion afterward, that'd be great.
Okay, that's cool. So I'll run through my presentation quickly then. Mine is actually a slide presentation. I'm not quite sure if everyone can see it, if it's on. Professor Zoloth, is it on?
Yeah.
Okay, great. I'm going to set up from beginning. There we go. Okay, so coming from South Africa, what really struck my mind was this discourse or framing of vaccine apartheid. And so this really captured my attention, and I was quite intrigued about this, because we used it differently in South Africa. And I grew up under apartheid, and so I was thinking, what is separate development, which is the meaning of apartheid in South Africa? What does that have to do with vaccination? So I started thinking about it, and of course the World Health Organization used the term vaccine apartheid. At first it was risk, and then we had entered vaccine apartheid. Of course, it was now more than vaccine apartheid. It was really, if one was quite correct, it was really about the vaccinated versus the non-vaccinated. And so even our own president in South Africa spoke about the vaccine apartheid if the rich countries hog the shots. So I was thinking again about South Africa, and is this term apartheid misused? Has it evolved because of the pandemic? For what effects are people using this word apartheid? And does using the term forget what really happened in South Africa and the oppression and injustice that was happening in South Africa under apartheid from 1948, 1950? But just a brief recap about what apartheid was, because it's been used very differently these days as on a global level. But there were many legal, apartheid was a legal system, institutionalized, systematic system of separate development. It was structure, it was material, and it was legal. So everything was legislated. And one of the main laws was the Population Registration Act of 1950, and we all were registered in different race categories. We still are unofficially when we fill in forms. We've got 4 racial groups in South Africa. But the thing about apartheid was the everydayness. It wasn't purely on a structural level. It filtered through our subjectivity, through everything that we did in terms of our movement and where we lived. There were many laws in apartheid in terms of how separate groups and separate races should develop, and they were segregated in what at that stage we called Bantustans. So we had the Group Areas Act, where people had to live in different areas, and these are just some of them. But the important one over here was the Group Areas Act and the Pass Laws Act, where people, where what was called at that stage the natives, had to carry around pass books called the Dom Pass when they had to enter the white areas. Mixed marriages were prohibited, as well as sex between different races under the Immorality Act. And there were various amendments to those acts. So what I did this in preparation for this for this talk, I decided to study blogs on the internet, and I Googled the search terms blog and vaccine apartheid on May 24th. And I got a whole range of data, and I looked and I read through them, and I used the first 80 search results that came through. Of course, not all of them were really blogs. Many were just repeated news reports. Many were press releases. So lots of things get put under blogs, even advertisements for disinfection services. So it wasn't really clear what was a blog, because I was really interested in how is this impacting people? What are the activists really saying on a personal level, and what is the activism about in terms of the blogs? But here are some of my brief findings. And I think we know this and we expected this, that there are two divisions in the world, and this is what the bloggers were talking about: the vaccinated developed world versus the global south. So there was the global north and the global south. The colonialist people were developed the vaccines, and the one suspect, or the one that was mentioned a lot in these articles, was Big Pharma, who were said to be in the driver's seat. There was lots of talk about the intellectual property legislation. There was talk about the investors and shareholders of the Big Pharma becoming billionaires and making more money. But key to all of this, so what stood out for me, was that South Africa was foregrounded in many of these blogs and activists' talk. For example, one activist said it's playing out again because they used the idea of the past of the HIV epidemic in South Africa, where people in South Africa who were infected with HIV could not get drugs, the ARVs, because of the costs. And it was playing out again, said many people. For example, when we got the vaccine to South Africa, what the South Africans paid was $5.25 per vaccine versus what the European Union paid, which was $3.03. So there was lots of talk in these blogs about waiving these property rights, and India and South Africa were mentioned very often. Ramaphosa, our president, feel free to stop me if I go over time, Prof. Zoloth, and our president was mentioned a lot as the spokesperson for the global south and for the oppressed. And I think he's linked to, he played a very big role in apartheid when Nelson Mandela took over, because he was very key in the negotiations and talks that led to the new democracy. So I think it was quite interesting that he played a big role in these blogs. Bill Gates was also featured quite prominently, and Israel to an extent. But I wanted to just maybe touch on, the tone or the discourse of these blogs. The one was desperation, that this was an emergency, it was a human rights violation, it was a race against time, and there was a crisis that needed to be sorted out quickly. The other aspect that came across in these blogs was the interconnectedness of, but not just in the negative sense because of the pandemic, but also people were speaking about the global family. And okay, thank you. Just very briefly, another frame was the intentionality of apartheid versus the intentionality now of the global vaccine apartheid, that it was quite deliberate by the global north. It was an ugly term for an ugly reality. There was lots of talk about dystopias and warnings and projections about when many countries in the global south or the less developed world will not be getting the vaccine. And one shocking statistic was that only in some countries, only in 2034 would herd immunity be reached. There was lots of talk about mutations, but the thing that also stood out for me as a conclusion was this idea about the vaccination pass, which is very prominent, as I said earlier on, as for movement in South Africa under apartheid. But now we have something, I'm going to go to the last one. And I think that what stood out for me is that now when we travel across the world or across borders, we've all got to show everyone this vaccine pass. And it might work for the developed countries. In South Africa, even the vaccination currently is not working because, well, I'm not saying we're not working. It's just that many people may not have cell phones to register. So there's a technological barrier. But I'm going to stop over there and give everyone else a chance, and maybe we can talk again about the pass and the vaccine pass in the group session. Thank you, everybody.
Thank you, Dr. Moodley. And then a wonderful talk and about a fascinating part of the world. I'm going to call next on Anna Bertie-Solman. Anna is a postdoctoral researcher at the Tilburg University Institute for Law in the Netherlands, and was the best swimmer of the group. Just saying.
Thank you.
Yes,
thank you, Laurie, and thank you all. It's such a pleasure to be here. Although virtually, but maybe exactly because it's virtual, we can be all of us around here. I'm gonna share some thoughts on a let's say quite experimental concept. I'm not going to use slides, but I hope you can visualize quite enough what I'm going to guide you through. So I decided to call this pitch Sensing the Unknown, and how the coronavirus pandemic is pushing us to engage with catastrophes deriving from hyperobjects. And this is inspired from a blog post that I wrote with a dear colleague that I will also post them in the chat. So I'm kind of fascinated by the concept of civic sensing, citizen sensing, which is basically a form of monitoring of various dimensions of the environment that surrounds us using our own senses and eventually also sensors. So there is a technology element, but if you think to what extent we as humans are living sensors and how important was the use of our own senses in these last months. So think that if you get COVID, you lose for a while or forever the capacity to smell. And imagine that as a human, these senses often are not that, let's say, appreciated, but without them, we wouldn't be the sentinels that we are. So these last months and now sadly years have taught us that there are possibilities for distinctive modes of engagement with ongoing socio-ecological disaster like the coronavirus pandemic, but also climate change that are emerging and in a sense require our attention from researchers. So we decided to kind of inspect more deeply this idea of a turn to sensing. So the fact that people are not longer being kind of passive receivers of information, but need to kind of take an active stand in the way they're processing the catastrophes going on around them. And this span from public health catastrophes like coronavirus, but also climate change and other disasters that are maybe more silent, maybe more long-lasting, but still will cause massive death. Now, we would like to quote Fleur Jones for her analysis of what she framed as a human attempt to elicit, receive, and process impression and information, both in the mode of intuitions and feelings, but also in terms of critical data. And so think to the importance of this sensing for the argument that we are making every day. So we, in order to be, let's say, less abstract, we wanted to kind of put this theoretical frame in context. And I have to say, I'm a quite empirically driven researcher in a sense that I always wanted to really dive into the empirical reality of the concept I was studying. So we really tried to look in the past months at how people were engaging with COVID informations in a way that was alternative from the mainstream production of information from institutions. So for example, we looked at these communities that in Italy started becoming kind of civic alerts for COVID hubs or COVID spread. But also we looked at the perils that can occur when the information kind of skip the mainstream channels and enter the civic arena, so also the risk of fake information. What occurred to us as a sort of minimum common denominator was this sense of engagement with hyperobjects. So hyperobjects are unfolding events that are so massively distributed in time and space that kind of overwhelm us. And so the pandemic was an hyperobject as such, but also climate change is similar in the sense that we cannot really understand the extent. We are just seeing it unfolding. And we, let's say, we imagine that both these silent or more sudden catastrophes are kind of obliging us to stay with the trouble, quoting Donna Haraway, but also not to just stay and watch the reality collapse, but also participate and try to build more livable futures on this damaged earth. So we think that researching the way people sense is a productive and constructive way to understand how we can fruitfully cope with risks that are associated with the pandemic, with climate change, but also, for example, with terrorism, with other, let's say, dimensions. And linking to, let's say, my own field of research, which is environmental law and environmental health law, is which kind of legal entitlements all these trigger. So we think that these kind of manifestations and responses to hyperobjects suggest the sort of essential need that humans have to access good information in times of crisis. And this makes kind of triggers the immersion of civic actors that produce information alternatively, like otherwise, when they perceive that they cannot access or trust official or mainstream information. And this happens both in the context of public health crisis, but also in that of environmental crisis. So think, for example, we could celebrate, sadly, 10 years from the Fukushima disasters. And there as well, humans needed to access information and they didn't trust the official ones. And so they started meaningfully create alternative platforms that still could benefit from the support of experts in order to be, let's say, scientifically sound. So all the sensing that becomes rumors, in a sense, is discarded by society itself. But when the alternative production of information becomes valuable and is recognized as such, then it also becomes a sort of important platform for complementing. And I will conclude just saying that I think we as legal scholars need to think to which implication all this can have for traditional legal entitlements that tend to put the citizen as sort of passive receivers of information, and eventually conceive, for example, a right to contribute to environmental or to health information in times of crisis. So I thank you for your attention and looking forward to the debate.
Wonderful. Thank you for bringing hyper objects into the debate, and also the link to, obviously, the link to justice, COVID, and climate change is a very strong subject for all of us. And rumors as sensory input and networks, human networks. I'll never forget that. That's great, Anna. Thank you. I'm going to now turn to Professor Bill Allier, the Emeritus Professor of Immunogenics, who has a lot of information about this at this time, at the University of Manchester, UK. Bill, take us away. Your turn.
Do I share? There we go. Is that okay? Great. So it's great to see everybody. If you can, the people that were with us at the brochure, you'll remember that I was there with Martin Newell, and between us we were working on the modern day pandemics, which were really focusing around chronic long-term conditions like diabetes, cardiovascular disease, COPD, etc. I'm pleased to say in the end we did get a book out of it, which came out earlier in the year. The publishers that we use, Manchester University Press, were incredibly slow, but actually it did us a favour in the end because COVID struck and we were able to put in an extra chapter at the end about the effects of COVID. And actually, what was, I mean, obviously it's an awful situation having COVID-19, but what COVID-19 clearly demonstrated, certainly in the UK and I suspect elsewhere in the world, is that the increasing prevalence of chronic long-term conditions, along with their associated factors like obesity and smoking, they've actually contributed massively and significantly led to higher rates of mortality and also increased critical pressures on the health system. So, really, COVID-19 has highlighted really the major inequalities and injustices in society that need to be addressed, and the majority of the UK deaths really are in people with underlying long-term conditions, obesity, multiple deprivation, and ethnic minorities. I'm just going to escape. That's better. I just want to, can I get rid of everybody's pictures there?
Yes, I can.
I'm going to do that because it's covering all my slide.
I'm sorry. Let's do speaker. There you go. You hit on speaker view on the top corner. When on the top of your screen, you'll see a little thing.
I think my top corner is covered up by all the images.
Yeah, you can bring you can pull that down, but we can all see it well.
Yeah, you can. I can't. That's the problem. So I just wanted to summarize a little bit of work I've been doing, looking at really the implications of diabetes, focusing on diabetes and what's going on with COVID-19 infection in the UK. It's very clear that people who have diabetes are at much greater risk of getting serious complications of COVID-19 and actually a much higher increased risk of dying. So we just looked at some of our local data in Salford in Greater Manchester, and we just looked between the period of March to October last year. And we examined the health records for a representative sample of the population with diabetes. And we picked out 308 type 2 diabetics and we'd confirmed them that they all had been infected with COVID-19. Now that 308 that we looked at as a representative sample, 56 of them, of the 308 died, with the peak mortality rates being seen in April and May of last year. So when we compared that to the 5-year average monthly mortality rates for type 2 diabetes, there was a massive increase really in Salford, 100% higher in March, 220% higher in April, and about 30-odd% in May. So those who died, when we looked at it in a little bit more detail, were significantly older than those who survived. So age was a definite factor. And then when actually we did some logistic regression to see what other factors might be implicated, obviously the one we were thinking about was obesity, and a couple of other things. Really, the only thing that came out within that was actually age. It's a very homogeneous population in Salford, and so we really had very little data on diversity, so we couldn't really look at that. But clearly it supported the finding really that people with chronic long-term conditions, and especially this one that we've been looking at, diabetes, type 2 diabetes, they are at much greater risk of having a serious outcome. So there's a certain large amount of injustice in that. And at the same time, actually, we've been doing some other work, which, although this graph is quite small, I'm hoping you can see it. I think it's a very interesting one. In Salford, we looked at a whole group of people who'd got type 2 diabetes. And because of the way data is organized in Salford, we have integrated electronic health records for the whole population that's integrated between primary care and secondary care. So what we can do is we can actually look, if we take time 0 on this graph, which is when the time of diagnosis is for people with type 2 diabetes, actually we can dig back into their clinical records and we can see what was happening to those people for years before they actually had a diagnosis made. And I think this is really interesting because, you know, when you look going forwards from a diagnosis, which is time 0, we can see all of the things happening that we expect in terms of multimorbidity and diabetes, like the development of renal disease, etc., heart disease. But when we look backwards, before they had the diagnosis made, and clearly a diagnosis is to some extent arbitrary because it's when they go to the doctors feeling unwell, but you can see that for 5 and probably even 10 years out before their diagnosis, lots of things are happening to these people. They're getting lots of infections, lots of chest infections, they're getting lots of hypertension, and they're getting you know, all manner of things going on. So this is a very interesting point because it means that there's a whole period of time before diagnosis when we could do something about it, but it also raises the question, are some of the people that are dying with COVID-19 that are not labeled as type 2 diabetics, it could well be what's contributing to their death is the fact that they're already on a trajectory for type 2 diabetes. So I think that's another interesting aspect of it. And then just lastly, although this is a slight off at a slight tangent, we also did some work on what happens to people with type 1 diabetes after you have your COVID-19 vaccination. And this all came really from an observation of an old friend of mine who's been type 1 diabetic for many years. And I was just chatting to him and he said, you know, I'm really well controlled and I have one of these Libra automatic sensors on my arm, you know, and it's monitoring my blood glucose all the while. And as soon as I had my first jab, my blood glucose levels went all over the place for days. So I thought that's very interesting. So we managed with a colleague of mine, we managed to get longitudinal data from the Libra database for 2 weeks before their first vaccination and 2 weeks after their vaccination of type 1 diabetics who've got these Libras on their arm. And absolutely, he was bang on. He was completely correct. Analysis shows that as soon as you have your vaccination, and it was the same with both the Pfizer and the AstraZeneca one, there was significant and quite irregular variation, big variation in blood glucose levels for 5 to 7 days after the first vaccination. So I think that's interesting. Also, some people who are type 1 diabetic go on to metformin as well to help sort of treat them a little bit better. And the ones who had metformin as well as their insulin, it was even more crazy in terms of the variation in their blood glucose level. So I don't know what the mechanism is. It's probably driven by the inflammatory response from the vaccination, but clearly people who've got type 1 diabetes and are being vaccinated, they need to be told to expect big levels in variation of their blood glucose, and they need to act accordingly. So I think it just opens up the possibilities, really, that when we think about injustice and what's going on, you know, COVID-19 is not a level playing field for who it's affecting. You know, whether you are obese, whether you are from particular ethnic groups, whether you have chronic long-term conditions, you know, it is specifically targeting certain people, and we need to be very, very mindful of that, and we need to adapt our policies and our processes accordingly. And I'll leave it there. Thank you.
Okay. Thank you, Martin. I appreciate that. And of course, congratulations on the book, the Boucher book, which reminds us again that, in fact, the deep injustice that leads to the underlying conditions that you and Martin identified are really played out again in this pandemic. I'm going to stay in England for a minute to speak to and ask Professor Ruud Termeulen to speak next. He's
I can't. There is a problem with the connection.
We can.
I can't hear you very well.
The little button, Bill, about stopping
Pardon?
your computer so that Ruud can start.
Can I start now?
Ruud, why don't you begin?
Yeah, I want to begin. I can.
Yeah.
Okay, there is. Okay, sorry. Yeah, I had a few slides, but I don't know how to upload them. But anyway, I think I have some. It's more. I have some. Pardon? Yeah. Well, I do have some theoretical reflections on the concept of justice and in connection with solidarity. I worked on that in a previous scholarship at Boucher, so I think that this pandemic does have also some theoretical implications for bioethical theory, because as Prevan mentioned already, is the interconnectedness of, we talked about the global family, and it means that what this pandemic shows is that human existence, human beings are very much interconnected with each other. And because of the spread of the virus, the way governments try to take control, the behavioral measures, the care, acute care, long-term care. But on the other hand, in view of this connectedness, bioethical theory is very much guided by some individualistic conception of human existence, of human beings as isolated individuals. And for example, the concept of autonomy, but also of justice, is very much based on this individualistic model of human individuals. They don't have relations with each other, but you have to talk more, bioethics talk more about rights and interests, and not so much about the relational aspects of human beings. What I try to do in my work is to view such issues more also from the perspective of solidarity, which is quite a European concept, but not familiar for example, in the United States or elsewhere. And solidarity means actually is the willingness of individuals to protect and to promote the collective interests for various reasons. And it can be because people have an interest to do so, but I would call interest solidarity, or because they feel a responsibility for the well-being of others and of society. And solidarity often starts in a very spontaneous way. For example, at the start of the pandemic, everybody thought we are in the same boat, and everybody accepted the regulations and the policies, and people were clapping for the healthcare workers. But after some time, this attitude, this feeling just fades away, and now people are more interested, let's say, how and what I call in their own interests, and how they're more. Just there is solidarity, but it's more based on, well, let's work together. But what can I? Because it's in my own interest that this pandemic goes away, and that's and also that, for example, the attitude against older people. There was what we call intergenerational solidarity is a bit shrinking. To say, was some attitude, for example, in the Netherlands. Why should I stay home, why do the older people not stay home so that I can freely go around in society and lock away the older people, the vulnerable people in the institutions? So solidarity becomes more limited, becomes more based on their own interests instead of the spontaneous feeling for we are in the same boat. This interest solidarity does not have, let's say, much room for feelings of responsibility for the well-being of others, certainly not at the other end of the globe. And so I think that instead of the individualistic model that's guiding bioethics, we should look also at more social and relational models, which example, solidarity is an example. Justice is similarly also based on individualistic idea of, well, it's actually what justice means is a fair distribution of benefits and burdens. And but actually it's also based on a sort of self-interest. There's always an idea in justice, what do I get out of the deal? What's for me in after some gift, what do I get in return? And so justice deals with the rights and duties of self-interested individuals, similarly as the concept of autonomy. But in the pandemic, this is a very limited model. It's difficult to understand our moral commitments toward vulnerable groups from the concept of justice. And I would then plea for the concept of what I call humanitarian solidarity, which I explain a little bit later. For example, if you look at the COVAX program of the WHO, includes just 36 million vaccines, which means only 3% of the 1.3 billion people in the program can get a vaccination. It's also disturbing that rich countries like the EU and the US have secured 87% of the vaccines, while, like President said, people in South Africa, Brazil, Turkey, the vaccine trials took place in those countries. So what is this, a fair distribution of benefits and burdens? I don't believe there's a fair distribution of benefits. The benefits go to the rich countries, but the burdens go to the people in the low income countries. So the justice has also a kind of what I call a kind of indifference towards the needs of the vulnerable and dependent individuals. It's also limited, motivated by what I say, self-interest, like, for example, in interest solidarities. It's important justice to recognize the rights and liberties of individuals, but I think it should be complemented what I would call by humanitarian solidarity. That's solidarity not so much based on personal interest, but also on identification with the values of humanity and responsibility. It's based on the personhood of people whose existence is threatened by circumstances beyond their control. And this type of solidarity, what I would call humanitarian, is captured commitment for the well-being of the other in difficult circumstances. And it's more wider than the concept of justice, which I feel is a bit narrow and based on self-interest. I don't think that it should replace justice, but solidarity is a kind of an important add-on, important correction against justice, because it's more based on relational aspects of responsibility instead of just self-interest. For example, the whole policy to open the vaccines, the patents for vaccination is, for my view, more guided by the self-interest of rich countries to contain the virus in the low-income countries, and not so much because there is a concern or responsibility. There are some good developments that the EU is now wanting to spend more money and to send more money to set up vaccine position in low-income countries, but we will see what will happen with that. So what I would like to say is this is the pandemic, but there are other situations where justice is, let's say, just one, let's say it's only one viewpoint, and we need a broader viewpoint to look at issues of social policy, to issues of health policy and social ethics. So that is why I think we can learn from the pandemic that we are, and our existence is very much related to the existence of others, and that we have a responsibility to our particularly vulnerable other people, not because of our own self-interest, not just because of self-interest, but because it's a humanitarian response to the needs of others. So that's what there's some theoretical reflections which I think link up with
Thank you.
what I'm going to say. Okay, that's it. Yeah.
colleagues, if you haven't read Ruud's book on justice and solidarity,
Thank you.
it's a must read, not only for all time, but for this particular time. I found it particularly important, Ruud. So thank you so much for thinking about it then, and also, of course, now.
Okay. Thank you very much.
Teresa Handel we're going to Germany now. Teresa is a research associate and philosopher and bioethicist at the University of Augsburg. And Teresa joins us now to talk about justice, who should be instantly.
Thank you. Hi, I would like to share my screen. Okay, perfect.
So good to see you.
It's so good to see you too. And thank you for having me. Okay, this should be working. Hi. So I want to talk a little bit about digital surveillance and the pandemic response and issues of justice and vulnerability. So at the beginning of the pandemic, since the outbreak, we have seen that digital pandemic surveillance and particularly COVID-19 tracing apps have been promoted as a mode to suppress the spread of the disease. And these technologies have significant advantages. They can provide information about high to low risk infection areas. They can also track the routes of infection and suggest to users that they should get tested because they might have been in contact with someone who is positive. However, these technologies also have risks, and in particular, they have the capacity, or any surveillance technology has been recognized to have the capacity within unjust societies to exacerbate the vulnerabilities of structurally marginalized populations, and particularly racialized people. There is a whole field of critical race studies that inquires or investigates how racialized people pay high price for surveillance. And this particularly is the case in centralized versions of COVID-19 tracing apps, which store data on servers controlled by the state health authorities. However, the discussions on the ethics of digital pandemic surveillance have largely focused on issues of privacy, transparency, open source code, data security, or uptake. And we haven't seen enough debate on structural issues of justice. So my colleagues and I have published this paper on pandemic surveillance in racialized populations. And as part of the work on the paper, we have collected rich evidence that COVID-19 measures have led to the disproportionate policing and criminalization of racialized people around the world. So these were just the finding of people who have presumably broke quarantine and etc. So we've seen that most people who were, for example, arrested in New York as part of these measures were Black Americans. We also have seen from the UK to Spain to Slovakia, Romania, that Roma communities and settlements were the first that were policed when COVID-19 measures came into place. So we argued in this paper that it is of crucial importance to interrogate vulnerability in COVID-19 apps because these technologies can provide state authorities with information about outbreaks in structurally disadvantaged groups, and they can exacerbate the already situationally vulnerable position of these people and lead to criminalization and racial profiling. We have also recognized that this is a complex issue because we have this evidence that racialized populations are more vulnerable to COVID-19 owing to socioeconomic inequalities and comorbidities. And we have recognized that precisely because of this, that the pandemic isn't affecting the population in the same way. Epidemiological data on COVID-19 infection and mortality are needed to capture the scale and forms of the inequalities entrenched and magnified by the pandemic. However, considering the risks of digital surveillance to vulnerable populations, it is of crucial importance to ensure that the development, implementation, and data use of this technology avoids exacerbating vulnerability and the risk of harm to survey subpopulations, while maintaining the benefits of data collection across the whole population. And this is something about my most recent work. The risks of harm from pandemic surveillance are even more severe in indigenous populations because of the legacy of colonial oppression and resulting socioeconomic inequalities. And I have worked with Native American scholar Tiara Roxanne, and we have looked into what has been happening in the COVID-19 pandemic in North America. And there has been a critical lack of data on COVID-19 in North American indigenous populations because of insufficient data collection and exclusion of indigenous communities from data sets, and also mislabeling of their data. Yet there has been some evidence that Native Americans are have been among the most negatively affected subpopulations. For the Navajo Nation in particularly, there were over 550 people reported to have died in 2020 on the reservation, making the infection rate over 2,000 per 100,000 people, which was really high. And we have also recognized that the socioeconomic inequalities that indigenous populations in North America face are really significant. Navajos are 67 times more likely than other Americans not to have running water, and communities with poor water access have significantly worse health outcomes due to everything from poor sanitation to increased reliance on sugary beverages, and which cause higher diabetes and obesity rates, which are comorbidities for COVID-19. And we have asked with Tiara whether digital technologies could help collect the much needed data and help suppress the pandemic in indigenous subpopulations, and how to ensure that these technologies would benefit indigenous health and well-being. And we have turned to the concept of indigenous data sovereignty, which is developing, and it refers to indigenous governance of indigenous data. And basically, we believe that tribal nations need data about their citizens, communities, lands, resources, and culture to make informed decisions about their communities. There is a real need for spaces which support indigenous agency and governance over their data. And it's important also for the fighting of modes of settler colonialism within digital spaces. So we argue in this work that is currently under review in bioethics that should digital pandemic surveillance technologies be wanted, and this is paramount, should they be wanted by the communities themselves, then they could be implemented in ways that give indigenous communities ownership over them, as well as power to decide which data will be collected, how they will be stored, and who will have access to them. And ideally, they should be designed by indigenous people themselves. And this way, digital pandemic surveillance technologies can stand a chance to be relevant to and beneficent to indigenous individuals, communities, their health and well-being. Because we really think that the colonial oppression and the socioeconomic inequalities in the indigenous populations is so significant. There is also a need for other responses than tech solutionism. And this is what scholars Close and Stone say about their work on COVID-19 and indigenous subpopulations in rural Eastern Arizona, that COVID-19 is a novel disease in need of novel approaches, but our experience has shown that there is no substitute for providing services according to the most basic principles of medicine and public health. In our current healthcare system, knocking on doors and talking to patients may be the most novel approach of all, because some of the most vulnerable communities are so deprived of basic health services that providing the most basic healthcare is actually a very important approach that haven't been tried yet. And I think in this respect, also considering what is happening in the world right now, speaking of vulnerable populations that have struggled with a systemic oppression, I think we also need to turn our attention to Gaza and how this Palestinian population in Gaza right now is in a dire need of healthcare with respect to the COVID-19 pandemic. Earlier this year, Doctors Without Borders, United Nations, and WHO raised the alarm, critiquing Israel's vaccination program for failing to provide vaccinations to the Palestinians. And the latest reports by Associated Press following Israel's bombing of Gaza informed that 18 hospitals and clinics are damaged, including the only COVID-19 clinic And when the clinic was damaged, Gaza had recorded more than 105,000 coronavirus infections, including almost 1,000 deaths. The head of the COVID-19 ICU was killed in a bombing. And Doctors Without Borders also raised alarm that this was a horrendous attack on civilians and civilian infrastructure, producing numbers of killed, wounded, and displaced Palestinians and shortage of medical supplies. While humanitarian personnel cannot enter Gaza, there is lack of basic health supplies and access to clean water. And the Associated Press quoted head of preventive medicine who said that it's like a ticking bomb because people are not tested and those who are infected won't know that they are infected. So this appears to be one of the major currently issues with respect to COVID-19 around the world from the perspective of justice and a vulnerable population in a dire need of help. Thank you.
Okay. Well, thank you. I don't have time to address or answer that now. Those of you who know me know that I can answer it, and I would at some point in the discussion. We have oppressed communities all over the world, and many oppressed populations, colonialized populations, facing very difficult situations, most of which we don't know about, and don't have anyone there talking on them and reporting on them and focusing on them. Okay, we're going to move from Munich all the way to Iran, where we speak to our colleague, Dr. Ali Kazaman, one of the, who did beautiful work on dentistry and ethics when we were together, whose work I have enormous interest in and support. Ali, glad to see it was published. Take us away. Tell us about Iran. Had a very particular view of justice and of course of the pandemic.
Okay. Hello, Laurie. Do you hear me? Okay.
Yes.
Thank you, everyone. Happy to be with you today. And what I want to put emphasis on that today is very in line with what Ruth pointed at. And it's to some extent related to the points made by Prevan. He called it just vaccine apartheid. And I want to just share concerns about what I would like to call it vaccine nationalism. Most of the ethical issues that has been addressed in literature during this year regarded the importance of prioritization of vaccination in different groups within each country. For example, elder groups or healthcare workers have to be prioritized. And very huge discussions happened about that. But I think the point that was really overlooked was the inequitable distribution of vaccines between countries, between what we could call North and East. So I think it's really what we have to pay more attention to that, because as Ruth pointed out, if we think about global solidarity, we have to be careful about what percentage of vaccination is happening in different countries, in different parts of the world. As far as I searched just today, less than 1% of vaccines administration have happened in low-income countries. And USA and China together have more than half of the vaccine doses just in the globe. And we could approximate this issue just by an ethical perspective to talk about unfair and unacceptable inequity that is happening these days in the globe. But at the same time, I would like to add to what Ruth made about the need to even point at self-interest solidarity in this sense. I think we have to be careful about we have to just talk about boomerang risk of continued transmission and emerging variants and mutations, that maybe this sort of justification might motivate global response to more equitable distribution of vaccinations. Because if we just try to use ethical literature, ethical words to motivate them, it might be insufficient. But as far as we know, if just high-income countries pay attention to vaccination of their own country and be just careless about the importance of vaccination in lower-income countries, in low-income countries and lower middle-income countries, it might result in more transmission of the virus and new mutations, and it even would have some boomerang risk for them. We have to talk louder that no one is safe until everyone is safe. And I guess that it's not enough addressed by bioethicists now in the board. We know that there are limited supply and mass demand, but it's really sad that high-risk groups in middle and low-income countries have not been vaccinated, while low-risk groups in high-income countries are going to get vaccinated more and more these days. And you've heard about that, for example, Canada have secured over 10,000 of scarce vaccines per capita, while as far as I've heard from the Director General, the WHO Tedros, he said almost a couple of weeks ago that just 25 doses have been given in one of the lowest income countries. 25, not 25,000, not 25 million. And it's really something that needs to be more talked about. And I think both approaches could be helpful. Ethical discussions and talking about unfair and unequitable distribution and the need for justice, but at the same time, we have to talk about self-interest, solidarity, as Ruth said, in terms that without paying attention to low-income countries, maybe more mutations, more transmission happens, and our current vaccines may not be successful in addressing this issue, actually. So I guess it's equitable access to COVID-19 vaccines in all countries is what is needed to talk about more and more. Thank you.
Okay. Thank you, Ali. That was very good. Interesting points. And I'm going to now turn to John. John takes us back to Australia, and where he is a researcher now, a postdoctoral researcher at the National University of Australia. And thank you very much for coming and speaking to us now.
So good midnight, everyone. So today I'm actually going to present about vulnerability within and beyond borders towards a just COVID-19 response, looking at how minority groups in Australia could actually be vulnerable. So as Laurie said, I work in Australia, and so people migrate around the world. People move around the world for a variety of reasons. Some move to meet with their partners, to be with their families. Others, unfortunately, are escaping war, conflict, civil war, and persecution. Whereas others just go to some countries to gain knowledge, to expand their skills, or to have additional work experience, or to have a gap year. And in Australia, in 2019, there have been 210,700 migrants, which has been a 16.5% increase from the previous year. And, in the discourse of COVID, we have known from what Bill said that, there are disparities in terms of morbidity and mortality of migrants with respect to COVID-19. However, it is not just morbidity and mortality that actually potentially render minorities and migrants harmed during this pandemic. So for instance, as we have seen, there has been a lot of racism towards people who are Asian, and with people actually spitting on someone, students actually being physically bashed or abused, and a family's home vandalized. And this is the most dominant discourse as to what other form of vulnerability ethnic minorities potentially experience during COVID-19. But is this the only one? And is COVID-19 the only thing that could harm people? Or are certain policies that have been imposed to actually prevent the spread of the virus also render particular groups vulnerable? So I will just give 3 examples in Australia as to how particular measures to mitigate the spread of COVID-19 have, in a way, rendered people vulnerable or harmed psychologically or morally. The first one is during the COVID-19 pandemic, like the Australian government have provided measures such as the JobKeeper and Job Seeker to supplement the income of people and to provide those who don't have work money to support their needs. And it's pretty substantial, which is like 2,000 Australian dollars or around 1,500 US dollars each month. But temporary workers and international students have been excluded from these measures, which is in contrast to what other countries such as Canada and New Zealand have done. And some of these workers have been in Australia for 7 years, much longer than people who actually hold permanent resident visas but could not just get permanent residency because they work in non-essential or non-skilled positions, as what the government calls. And the Prime Minister said, as much as it's lovely to have visitors in good times, if you are a visitor in this country, it is time to make your way home. And unfortunately, this has rendered a lot of people, some students, even homeless. And I've been an international student and I have a lot of friends, and this really speaks to the core of what vulnerability is and what the layers of vulnerability are during this COVID pandemic. Another thing would be the lockdown. So we had an outbreak last August. And one way that people have thought to mitigate it was to actually lock down instantly people in a public housing tower where there is a lot of cases. And this is in stark contrast with what has been done with other suburbs. So usually in Australia, when towns or suburbs are locked down, people are given at least 20 hours to actually prepare. And with this, in contrast, it was just like, after I announce a lockdown, you cannot leave your home. So this was very, contrasting. And obviously these are people from underprivileged backgrounds because they live in public housing, and there are a lot of refugees, and they had like at least a 10-day lockdown. And during one of those days, actually fences were erected in the premises to make sure that these people don't go past the buildings. And obviously for people who are from war-torn countries, which comprise some people who live in that place, then definitely that is immensely traumatic, because excessive policing for people who have been in a country who has been bombed is just, could induce PTSD and so on. And the latest one is that, as we know, unfortunately, there has been a recent spike in cases in India. And the Australian government has actually banned people from India from returning, even if you're an Australian citizen. And those who actually have been returned could face jail time of 5 years and potential fine of up to $66,000. And this was heavily criticized because such measures were not imposed against the US or the UK, even when they actually had a higher, in fact, when the number of percentage of people infected with COVID-19 is actually much higher than in India. Obviously, it's like the government does not reflect its people, but then unfortunately, these policies that, have potentially controlled COVID in Australia have also rendered people vulnerable. And I think it is really important to think of those left behind by certain policies and to develop more inclusive policies to address COVID-19 outbreaks, but also to ensure that we empower and engage racial minorities, especially in times of crisis during COVID-19, because in this pandemic, we all matter, and we cannot achieve global justice unless we achieve local justice in the places we live in. Thank you very much.
Thank you to all of our panelists. The Berkshire Institute as a foundation has given us an extra 10 minutes to take your questions and talk among ourselves. And I would like to hear what you thought of one another's talks. If you have anything else to add. Anyone have any questions from the audience?
there is a provocative question that I'm reading.
Yeah.
So
Thank you.
I'm not the most equipped on racism and COVID, so I would suggest some of the colleagues here that are more working on that could take them up.
Well, I was just trying to write a reply and I'm halfway through it, but it'll probably take me forever to do it. But my comment, I mean, it's not a proper reply to the question, but I'm not quite sure osteoporosis is a very good one to compare it to, really, because it's, you know, with osteoporosis, clearly it's a serious condition in many people and especially the elderly, but you don't usually get it on your death certificate and it doesn't usually kill you. Whereas with COVID, you know, it is a killer virus for sure, and it's absolutely ravaging through the populations. But I would agree that, you know, people have been very keen to shift the blame or use it in a provocative way to blame other countries. You know, I mean, how completely disgusting was Trump and other people to try and blame this on, you know, call it the China virus. You know, I mean, it is just despicable.
So one of the things that at least we don't blame osteoporosis on any country. One of the things that's really interesting about all of your talks we've had these talks when we were together in our summer camp was the centrality of justice. In Chicago, where I live, we saw this play out exactly on racial lines. Within the first few weeks of the epidemic, it was clear that in the north side of Chicago, which is white, segregated city, versus the south side of Chicago, the death rate was completely skewed around race and class lines. And that continued all the way through to the distribution of the vaccine until people, we have a bioethics coalition in Chicago, and many people from that coalition went this out, showed the map of where pharmacies were, because it was distributed in pharmacies much more heavily distributed, of course, because there's more pharmacies in white neighborhoods than in black neighborhoods. So the division was really quite stark. And then the city, seeing that, made Laurie Lightfoot, actually the mayor, helped put together a special program called Chicago Plus, and they deliberately went to zip codes with high death rates, which were, of course, the zip codes where persons of color largely live in our city, and deliberately gave the vaccine first to those zip codes. And as you can imagine, that caused some comments among people who felt like that was unfair, or whatever. But in fact, the city pulled together and, in fact, went forward on that vaccination policy. So the zip codes now that are targeted in the city have been in the black and brown neighborhoods that have been most highly affected. And there's mobile units and there's mass vaccination sites. And Chicago has vaccinated 50% of the adults in the city of Chicago, black and white, have at least one shot, and almost 40% have both shots. So they're making real progress. But the first flush, the immediate response was to just fall out on racial lines once again in the city of Chicago, so that it drew attention to something that people in our field, bioethics, have known, of course, for our entire careers, which is healthcare is distributed on racial lines, and it is discriminatory, and people who are disproportionately poor, disproportionately African American or Hispanic in the United States, in other countries, whoever is the poorest, whoever is the person of color, whoever is marginalized, whoever is a refugee, new immigrant, whatever, those people are less likely to get the goods and services of healthcare. What was surprising in America was that we had this fiction that we were all prepared for such an epidemic and had stockpiles. And it turned out we had stockpiles of Tamiflu all around the country, but we did not have any way to cope with this, and we did not have any way to deal with the split in American politics. Of course, the deep division in American politics, and what happened in our country that made the death rate so high was the politicalization of our reaction, that it became a political issue and not a public health issue. Yeah. So that, and I think Anna has pointed out the connections between how societies react to this crisis, this hyper-object, this enormous pandemic, will be how we react to climate change unless we do some serious work around changing that reaction and shifting us towards justice.
I think equally as important, Laurie, is the sort of the discrimination really based in terms of how people view economies as well, and you know, the whole purpose of making money in the market, you know, because you may well be aware of the news yesterday in the UK, where, you know, somebody came out from the who'd been working in the cabinet and said, yes, Boris Johnson had said, I'd rather have bodies piled high in the street rather than have that than having a third lockdown. You know, well, if that's been the message from on high, you know, and also saying, well, the death rate is predominantly in the 80-year-olds, so we shouldn't worry too much. I mean, the whole ethos is one of discrimination, and one that's appalling, really. So, you know, I despair.
Okay, this is, you saw Alexander, Alex Cafferin's question to you, Bill, which is that his question was, would we say that all the measures used, such as monitoring, were racist or unjust? If not, is it because the actual distribution of COVID-19 made the worst off more badly off, and hence anything done in responsible is potentially racially unjust?
Yeah.
Right, so that's.
I think if we know that some people are at high risk of dying, regardless of whether they're elderly or whether they're from a particular, you know, heritage or whatever, or whether they come from, you know, an area of deprivation, if we know that those risk factors are higher in those people, those are the people that should be having the vaccine first. Simple as. Why would you not do that?
Right. Thank you. We the other question I wanted to ask the panelists, we're getting people asked us about our selection criteria. I want to say I'm quite proud of my panel. This is among of all the brochure panels, I think it was brochure panels, it was one of the most diverse, gender balanced, finally, and one of the few good things about this pandemic was our increased use of technologies that allowed all of us to speak together across, as you see, 7 different countries. And that's quite extraordinary and wouldn't have been possible prior to this use. So that's something we want to thank the foundation for bringing us together, and for all of you for coming. Any final thoughts?
No, it's just great that, you know, we have a single voice on this, I think. So that's great.
It really is. Go ahead, Joe.
That's all right. I think, you know, people have always asked about racism and what if it's just one group, but I think it's always important to look as well at the historical context. And racism does not just mean discriminating one group against another, but also looking in a way, you know, for instance, how the yellow peril against Asians, or, you know, how the bamboo ceiling have pervaded and have actually been persisted throughout the years, and how COVID has actually just made them more apparent is important, because racism did not just happen today. You know, there has been a rich history of it, and we need to acknowledge it in order for us to address justice, not just with COVID, but with other chronic conditions that disproportionately affect ethnic minorities.
Okay.
Thank you. I think it's really important to remember that we will leave COVID eventually, because all epidemics end, but we won't leave these structural situations, the structural racism, the injustice that are embedded in our systems. I want to thank all of you for coming today and speaking, and your work is beautiful. I can't wait to hear more from each of you. I can't wait to work with you more. And thank you all of you for bringing, especially, you know, those of you Teresa, who brought attention to the most oppressed communities, bringing attention to oppressed communities around the world. Anna, for reminding us about the hyper objects and the importance of sensing in a disease that was like all the bad guys were wearing invisibility cloaks. You couldn't see the disease, you couldn't see the invaders because it was invisible, but and then the loss of senses, the attention that all of you mentioned about monitoring, and the potential misuse of monitoring as both an instrument for justice, but an instrument for injustice as well. For Ale and Previn and Bill for reminding us about these underlying structural injustices once again, and for Ruud, of course, for bringing us home with his wonderful work on the European principle of solidarity, and our attention to it in his. So I thank you for your lifetime of work here, and for the wonderful summer we had together, and also for your time today. It was really lovely to see you all and hear what you are doing. Thank you very much.
Thanks, Laurie.
Thank you.
Thank you, Laurie.
Bye.
Hope to see you all soon somewhere.
and alive and,
I also
touching each other.
yes.
I also
love
just
to
wanted
see
to say how I appreciated the focus on solidarity. I think that we really need to think more about solidarity internationally and with respect to justice.
I think it's really important. I mean, and as we were discussing offline, Teresa, that it's really important because nationalities, even national liberation movements, they're deeply vexed at this point in our history that there's other mechanisms, and solidarity represents a possibility for other mechanisms, especially as we face climate change, which is the next enormous challenge that we face collectively. Also elusive, also politicized. Well, I wish you all well.
Thank you, everyone.
Thanks, everyone. Thanks, Laurie, for organizing this.
Okay. So keep safe out there, locked down in Melbourne, and keep safe, everybody.